So my name is Eileen Gorman, and I guess I have two roles with VistA. My sort of historical one and my current one. Currently I'm one of the directors on the board for the VistA Expertise Network, and I was requested to do so because I have a fairly long history with VistA. So I started in the San Francisco VA as medicine residency coordinator, and was the person, the VA uses a term called ADPAC, Application Data Processing Application Coordinator. And they're the people in the service lines who know the system the most and train everyone else on it. And so I got very familiar with the user side of it. We went to the TIU implementation, which is where they started to expand into a true electronic medical record out of just a lab package, a pharmacy package. So I started training my service line, and from there I got hired to train the whole hospital. And then I got hired into the IT department to be the trainer. Became a clinical application coordinator, assistant VistA manager, MUMPS programmer, and the help desk. So I learned a lot, and one of the gentlemen, our VistA manager's name was John Harvey, and he moved up here to Seattle. And about 2 or 3 years later, after some not very good things that were happening at the San Francisco VA, I left and came up here too. And although I hadn't actually expected to get a job at the Seattle VA, I ended up getting a job at the Seattle VA. And I was hired there as the information security officer. So my current relationship with the VistA system and the electronic medical record is more from the side of security and privacy, data security, ensuring people are using the system correctly, both to meet the laws and regulations that are required, but also because I'm extremely passionate about all that our veterans have given us, and that people need to pay attention to the fact that the data they're dealing with actually has as much of an impact on our veterans' lives sometimes as the health care they're giving. My key thing I will often say to people at new employee orientation is, it's really awesome that you just, helped this person recover from, a very bad, medical condition, and then they go home and discovered that everything they have has been stolen because you didn't bother to protect their information because that wasn't important to you. You don't make them vulnerable in one way while making them better in another, and so I take that very seriously. But I do have a really passionate commitment to healthcare and the fact that we need to be doing something to give the best healthcare, not just to our veterans, but to anybody and everybody who can. And so becoming part of the VistA Expertise Network was a really wonderful opportunity to be part of a nonprofit organization who's really committed to just improving healthcare for everybody in the way we think that is important, which is that you make the information available in a way that people can use when they need it, and you get the tools that people need in the hands of everyone who needs it, and it's not just for the people who can afford it. Healthcare should be for everybody. It should be absolutely a base thing everyone has, not just has access to, but just gets. End of discussion. So it's very key for me. And I believe that one of the things that Tom had been talking about was, patterns and histories and stories about VistA. And one of the very first things that came to my mind that I thought, from my standpoint, of something that I saw as time passed, so to speak, that was important was sort of, let's say, a positive thing and maybe a negative thing, I'll put it that way. So the negative, interestingly, and to me this is a VistA thing, I'm not so sure everybody else will agree. So, so the VA has gone to a regionalized data platform for their VistA systems, which is to say, it used to be that every hospital had a VistA system in the hospital. It was maintained at the hospital. Then there was a decision, for a variety of reasons, that it would be better if we had regional data platforms where the VistA systems were hosted and maintained there. No data, so to speak, resided at the facility. No computers resided at the facility, so that basically the OS and general support system went elsewhere, and the only thing we retained was, in essence, the application kernel, taskman, and the part that does it. Well, one of the very first things that came up within a month of that happening was that the system went down. We had very little outage that wasn't planned outage prior to that. But once you went to where you were reliant on a wide area network and other people managing your connection, we had a lot more downtime, which was very negative for a lot of people, because it was like, why is this suddenly not working the way it always used to work? But the issue here was that we had something that went down probably, let's say, about 2 or 3 o'clock on a Friday afternoon. So pull up a big conference call, everybody's sitting down, they're working through, here's the symptoms, what are we seeing? And then at 4:30 on Friday, the 2 people at the regional data center said, well, okay, so we'll see you Monday. And the 3 hospitals that were down were like, whoa, whoa, wait a minute, what are you doing? And it was, well, it's 4:30, it's Friday, it's time to go home. It's like, no, you're supporting a hospital. We're here until this problem is fixed. And their response was, I don't work for a hospital. I work for a data center. I go home at 4:30. And they actually had to end up calling like the chief of the whole region to get those people to stay. And when I've been listening to the various conversations, one of the things that I heard that I thought, you know, there's a lot of talk about development and how we're going to do this and, oh, how a hospital over here. But Rick made a point at somewhere about the fact that you've got to train users on the ground and it's best to have a super user at the hospital. And, you know, some people were kind of going, well, you know, okay, if we could. And the answer is you have to have somebody at your hospital who has some aspect of control over this computer system because then they own it and they care. There are a bunch of developers out there who would think, ain't it cool, and I would love to work on this little tiny package, but you need somebody for whom this is my patient right here, right now, and I need this fixed now. And not, well, that's not my job. My job's to do some programming, and I'll get to it when I find it interesting. There has to be not just I really think it's important that wherever this is implemented, you have to train a doctor, a nurse, an admin person, more than of that if you've got a big enough place, not just because then they can help train other people and they can be the advocates, but when something goes wrong, they are the people that will not leave until it is fixed because this is patient care we're talking about. And the people in the room so far all came mostly out of patient care, so they're equally committed. But I think a lot of the new people coming up doing development or doing programming, it's just a really cool system, and they might have a sort of, let's say, an intellectual commitment to healthcare, but they don't see Mr. Jones every day, and they're trying to get him better, and they don't have that visceral connection the way somebody in that clinic, in that hospital, in that healthcare system does. And so that would be something that I would say is a lesson learned that I really took away from that. And although some things are better, that we manage your computer system's distance. It's another thing I don't sometimes like about buying things from a vendor, because their focus is not how can I make this the best thing possible so your patients get done. It isn't. The way that radiology tech on the ground, that's what they're most committed to. So making sure that you've got those users, those end users, those super users involved at every step of the way is what's going to make sure this actually applies and commits and helps the healthcare, in my opinion. Sorry about that. No problem. And then the only other thing I probably had to say, I was thinking about this. I thought I had something slightly more coherent, but when I was asked about it last night, I couldn't say it very well. I noticed that when I was doing the training, so this is interesting, and to me it's interesting. I think there's probably been a change in the last 10 years, because when we first started implementing this in, well, it's been more than 10, maybe not, it's about 94, 95. You know, one of the most interesting selling points to me and how excited our nursing staff and our clinical staff, the doctors, the nurses, everybody got, was that, you mean 10 of us can be in the record at the same time? You know, if you go from a paper record to an electronic record, there is this leap in which suddenly you go, holy, I can do all this cool stuff. And you didn't have, I mean, that was one of the things that VistA always had from the beginning that other electronic medical records actually had a really hard time with, which was the not having a conflict if two people were doing something in the record at the same time. I presume, excuse me, I think because VistA ticks things down at like the 100th of a second, and other systems didn't think to go to that extent. You know, you can have 5 people, and as far as it looks like to the outward eye, all 4 of them click enter at 12:52. And in other systems, you would sometimes go, oh, well, I can't write that because somebody else is using the record right now. And that does not happen in VistA. You can have 100 people charting in the record at the same time, and it will not conflict, and it will work, and everyone can see. And if you, go from one page to another in CPRS, it updates so that if somebody just finished a note, now suddenly it appears. And that was like candy to children for these guys. And I don't know how much the expansion of EHRs and what they're like in other hospitals is whether or not that's as much of a wow grabber moment. But in implementation, often when doing the training, showing them how they can do something more efficiently, or here's an easy way, that will get you your super users and your enthusiasts, and I want to turn around and show everybody else this really wonderful thing. Because I'm a key on education. You got to spend the 10 minutes up front because you'll save yourselves hours later on if you show people how to do something. But once you show one enthusiastic person, then they go around and show everybody else. The peer-driven stuff was really big. The CACs would teach people something, or I would teach people something, and then the next thing you know, the docs, the residents, the nurses would come back and show you something that one of them had figured out, and now they've all told each other how to do it. Especially, again, in a hospital situation. But most of that education is going to be peer-to-peer, which is another reason, sort of feeds back into that super user thing, is very important. But they tend to show each other a lot. Did you know you could do this? Did you know you couldn't do that? And if you can get one of them committed to some sort of standard guideline, in my case, obviously, it would often be sometimes the security stuff. If I can get one of them to commit to the security stuff, then they are my advocate out there, because, you know, otherwise it's just, oh, that's Eileen, you know, yeah, she's always telling us not to do stuff like that. And if I can get one of them to see why it's really important, then they become the advocate, and that helps a lot. But that peer network of how they show each other what to do and how to do it is another reason why the user is so key, because they will often come back and go, hey, look, we're using it this way, which is not something you, the developer, expected. And now that you see how they're actually using it, you can refine it and make it work better for them, and then that gives them even more ways in which they can use it. This morning at breakfast, we were talking about possible applications. We were thinking, would this be interesting? Would this be interesting? And one of the clinical application coordinators, CACs, is here from the VA, the Seattle VA, and he was going, oh, no, that's too much work. My docs would never do that. And I said, I disagree with you. I said, because you're saying that on the thought process that we would go to the doctors and tell them they had to implement this thing and they would have to do it for all 100 of their patients. And that's wouldn't be what we'd say. It would be more like, if you ever wanted to do this for a patient, it's available for you. Oh, well, it's still too much. I said, I've had way too many doctors come up to me and say, can't I just do this one thing for this one patient because something irritates them or they want to make a change, or it really only does apply to one patient. And VistA at the moment is written, it's kind of an all or nothing. And we were talking about maybe being able to customize certain things down to an individual patient level. Michael doesn't hear the complaints that I hear. I think it would actually be very valuable. He doesn't see how anybody would apply it. So you, the developer, don't even always know how people are going to end up doing things. The person on the ground is the one who hears, and not even always the same things. Right off the bat, I could think of 3 doctors who would basically be off my back if we had this tweak. Michael's never even heard that complaint. So it's very interesting to me. I'm like, really? You've never had anybody say that would be useful to you? But he tends to come at them as a, he's the teacher at the hospital. So I don't think he gets that feedback loop quite the same way I do. So it's just very interesting. Just listen, having somebody on the ground who can listen, pay attention.
How would you propose deploying VistA for a small community hospital? I've got a 14-bed hospital on the Gulf Coast of Texas. They're not going to have an embedded geek.
Right.
Do you think that it's a worthwhile endeavor doing something remotely for them?
It is. It is. You don't the embedded geek would be great. But if you have that one nurse manager, that one doctor, that one business manager who knows the system well enough to at least be able to identify what to ask for, who's talking to the docs every day and the nurses every day, and here's the, this is great, and if only it could do this one other thing, so that they're the person that goes back to the, I'm saying licensed, and that's not the right term, but the person who's agreed to, or the group that's agreed to be your support. An embedded geek is awesome because that's the person who can right then and there go and say, but at least the person who's there who's the most knowledgeable about the system. I would deploy by showing a group, and then at the end of it, because this is kind of what we did at the VA, you'd like do your basic presentation, and this is what Rick was saying, they will appear. Inevitably, 1 or 2 people would go, I've got questions. And that's the people you say, come with me, let me show you more. That's the person where you get them to play with it first. And just watching people, I would often say, what's the thing you do the most often? And they'd say, well, God, I got to put in 1,000,000 progress notes today. Okay, let's work through a progress note. Watching them use the system, sometimes even watching them just use the system, gives you the, ooh, I keep seeing how there's this hesitation where every time they get to this one point in the process, it either takes 6 steps or they got to go back, or whatever. And you can see places where and under implementation, I would hope at least there would be some technical people there to see that. But you get them to be your advocate, as much as possible, your expert. Then they become the link to the super geek. And I bluntly agree with Rick, after a while, they'll start saying, well, can't I do this myself? It'd be so much faster. And then you give them the tools to do it themselves. And then slowly but surely, they become your embedded geek. The more they learn, most of the time, the more they learn, the more they want to learn. Almost every clinical informatics doctor at every VA facility started out as a clinician who just thought VistA was really cool. And as Rick said, and very unfortunately we all agree, once it got to a certain point, the VA basically said you can either be a doctor or you can be in information, but you can't be in both. So, and pretty much 90% of these people, mostly men, but some women, said, I think I can do better, I can have more of an impact, and they all went into the IT side.
Can you speak to the security of VistA?
Yes, not necessarily the way other people would like me to, though.
Just 1 second.
I'm sorry, Mike.
I'm going to move this.
Okay.
As
No problem. So VistA is actually an extremely secure system. However, most of the security of it right now is bluntly based on security through obscurity, although some of the developers might not necessarily like that statement. And that's because it isn't out there. It's not a big, broad thing. And so there's like, it's not like there's viruses written for mumps. It's not like there's viruses written for cache or kernel. Nobody even knows that's out there, the people, the hackers and the crackers. I do know that there is a certain amount of embedded security. And I know that it is a heck of a lot more secure just at the base way they made things work and how communication happens in some of the channels. But I don't think it's hack-proof or crack-proof. I just think nobody's ever bothered. And the issue with the system at the moment is not technical in the way people mean technology, but technical like it's technically this or it's technically that, i.e. legally. The problem with VistA in the VA is that all these federal regulations apply. And the federal regulations are written basically as if every single computer system is more or less a networked sort of Microsoft-based system. And the problem is nobody will certify, in fact, it hasn't ever been truly certified as secure, even inside the VA, because you can't meet the standards because the standards don't apply. But unfortunately, the federal government, or the way most of the auditors are applying it, don't give you the option to simply say it doesn't apply. I have a little metaphor I use when the OIG come and what are called the ITOC auditors come and the SCA visits. I have like 5 visits a year, and I pretty much have to give the same metaphor to all of them. But it seems to have worked, which is that the network, the LAN, the WAN is an airplane, and VistA is a Volkswagen. They are both transportation devices. They both get you around. VistA is awesome for getting you around the city, that little Volkswagen. Not so good about getting you from here to Albuquerque. But that plane is awesome from getting you from here to Albuquerque. Not necessarily so good getting you around town. But all the rules and regulations are written for the airplane. So these guys come in and look at your Volkswagen and go, well, I can't pass you because your wings don't do this. And you're like, yeah, we don't have wings? And they're like, yeah, but the regs say your wings have got to do A, and your wings don't do that, so we got to say you failed. Non-applicable doesn't seem to be an option. Or, well, we don't have wings, but we have this other thing, and here's how we've made it secure. No, but it's not a wing thing, so you don't get to pass. So the only worry I have sometimes, you know, they were talking a lot about EWD is very secure, which was a fair amount of people saying it's very secure and nobody actually showing me how it was secure. Or perhaps some of it might have been based on technology that I was supposed to understand that this particular protocol was awesome. I just don't happen to know that off the top of my head. But I do know that if any of these systems are going to have to be certified under certain federal or government regulations, they may find themselves in more of a sticky wicket than they think, because you are not going to have people who actually understand VistA applying the rules to VistA. You're going to have people who understand networking trying to apply the rules. And often they cannot, it doesn't matter how long you argue and how much you talk about that's not applicable, or here's how we're doing it in this way to meet the same standard. I've sometimes won that argument because I get somebody who's logical and who listens and is rational. And a lot of times I get people who go, I don't actually understand any of what I'm trying to apply. I was just told the answer is this. You're not giving me that answer, so you're failing. All the new stuff, EWD, the way it's integrating. George and I talked about Mailman a little bit. Mailman doesn't meet any of the standards. It's got Scramble, but I've never heard anybody actually explain it in a way that would meet an outside regulator or auditor's definition of secure. It always seems to boil down to nobody knows how to look at it right, so therefore it's fine. And that always leads me to worry, well, what if somebody someday figures out how to look at it the right way? Is it still truly secure at that point? The VA is all about defense in depth. You've got to have security at the firewall, then you got to have security at the server, then you got to have security at the workstation, and then you got to have security on the person. They want all four of those in place. And a little bit of VistA strikes me sometimes as, well, we've got this one middle part done, so we don't have to worry about the rest of it. And that's not how the security community tends to look at security. So I feel a lot like it's somebody who says, well, I locked my front door, so my house is fine. You're like, upstairs windows open. Nobody will go up there. It's too hard. Because they wouldn't do that. So why would anybody else? And you're like, see those 17 people with ladders? There. And it's true that although, let's say, medical fraud and theft is a slow-growing factor, it is growing. There are people who will attack medical systems precisely to get all that data that's in there, not necessarily the medical, but sometimes just the identifying data. Because they're beginning to learn that sometimes those systems are not as well protected as the banking systems. Banking systems are clearly your honeypot. That's where everybody wants to go. They think that's where the money is. But some people are beginning to realize that same data resides in other places that aren't as well protected.
Can you speak to your engagement with the VistA community?
Yes. We're trying to expand it. And the last year, the VistA Expertise Network realized that we talk amongst ourselves a lot, and individually, being at the VA hospital, I talk to other people, individually Art being with the people he knows, individually George being with the people he knows, Rick being with who he knows. But as a group, as a board, making sure that we're out there really hearing, what do the developers want? What do the users want? What do the adopters want? You know, our beneficiaries basically start with the patient, go to the users, adopters, developers, the whole community, and then basically everybody in the world who would ever need healthcare. And we need to be out there more listening to what do they want? Or recognizing that sometimes when they say, I want to be healthier, we think the way to do that is this way. You know, I'm sure absolutely a lot of people would say, I want a nice new brand car. We can't give them that. That's not part of healthcare. So this is probably one of the first steps we have to really making sure that we're connecting. Because I think for me in particular, most of my connection was through Rick and the people I talked to at my VA hospital, but not much broader than that. And we need to broaden out. We need to be hearing the same, we're hearing, I've heard what Tom had to say through Rick before now. I've heard what Phil had to say through Rick before now. Bob through Rick, Denise through Rick, and to hear them directly, not that there's that much filtering going on, but it's still good to hear them directly. And so that is what I want. I want a bigger and better integration and communication with the community, which I haven't had up until now. And I think, A, because I work full-time, but also I think it's important if we want this to keep going further forward. I'm happy with these 4 days, because it seems to me a lot of people came here kind of like, okay, I'll give it a shot. And like me, within a day or two, were like, this is working out great. I'm really talking to, you have people who their methods for achieving the goal in some cases are completely polar opposites, but the goal is the same. And there's a willingness to say, okay, the goal is the same. What can we do to get these methods at least that we don't fight each other? How can we, integrate as much as what's possible for the way I think this should be done and the way you think this should be done? People of goodwill who say, I really think it's important we do this, but in the end, it's really important that we achieve the goal and not that we do it my way versus your way. Get to that goal the best way, good enough, what gets us started, what's good enough to get started. The proof is in the pudding. The best way will shake out over time, and the best way may be 6 different ways. I do a lot of adult education, and one of the first things we really have to learn, you've got to internalize, is people learn differently. You can make a course that 80% of the people who take it will walk away learning everything, love it, great. 20% will not get anything of what you've said. For them, you need something different. And you don't change the whole course and now make it so that all 100 people have to do what works for the 20%. Sometimes you need different methods to get to the same goal so that people's different way of learning, different way of doing meshes. If you try to force everybody to do the same thing, you're just fighting yourself. You need to recognize we all have different ways of doing the same thing. As long as we get there in the end, that's the important part. for me.
Do you feel that VistA is the right solution to meet the needs of the healthcare community?
I would say yes. My familiarity with VistA mumps, what I like most about it is its absolute adaptability. I think it's the best for two reasons. Number one, it was built by people whose entire focus was, how do I get this job done? As opposed to which is a sweeping generalization, I recognize that right now, but it feels to me like 90% of the vendors out there trying to sell something are, what can I get out there that will make me money? And so it has to be good enough so that people want to adopt it so I can get money. But it wasn't built by people who could care less about money, who didn't care that, in point of fact, whether it was or was not economically viable. I forget who said it, but I have to agree with them. It was only in this sort of government situation that it could have been developed, I think, in the first place. Because although this is, I think, truly not the reason why most people get into healthcare, and it is not the main focus of like a community clinic or a community hospital, the simple fact of the matter is everything at a VA hospital is aimed at, how can I get this guy healthy as fast as possible to get him out of here because he's costing me money. And no place else is that actually true except possibly at, a county general or a charity hospital. But most of the hospitals have some form of a for-profit, or at least I got to make enough profit to keep going. And admittedly, not that we've ever had enough money to keep going, to a certain extent being a government facility means we're going to assume at some point in time the taxpayers, we don't have to worry about, have we billed enough? Oh my God, we had 100 patients and we were only able to get money to pay for 50 of them, so now we're screwed. Those all 100 will be paid for. Maybe not as much as we'd like, maybe we won't be able to expand as much or do as much, but the money will be there. We never had to worry about that part. Everybody else has to worry about the money part. And so some aspect of their software development always has something that doesn't see, I would basically say that to a certain extent VistA was 100% focused on patient care. I don't think anybody else is truly able to develop medical EHR software that is that way, because they're a business. And some part of how they're developing, some person involved in that, the first and foremost thing they're trying to think about is, can we make money off of this? Because you got to sustain it. And that's kind of the whole point of a VistA open source community as well. You've got a whole bunch of people committed who could care less for the most part. Making the money off of it is not the foremost thing they're trying to do. Being able to survive while they do it would be awesome. They would love to make some money off of it, but it is not the foremost reason why they're doing it. And then just in and of itself, because of that, you had, 100 different people working on it from 100 different ways, but with these set a series of constraints. We'll use this language, it's got to work this way, but after that, go nuts. Meant you just have so much flexibility. Add, remove. I mean, when he talks about extensible plug-in mod, expensible little nodes and that is just really, most people try to build one coherent system. And these people building it could care less about one coherent system, except at the end result when you've got one coherent presentation, that's what they cared about, not the system to get to the presentation. That could be the heck all over the place. And it is, and it was. And that allows you to adapt and change it in ways that I don't think is quite as available to you, even in possibly other open source healthcare, because people are always, they were groups trying to create a coherent thing. And we really did start with a lab package. Oh, well, all right, let's add a pharmacy package. Well, while we're here, we should do a billing package. Well, we need a scheduling thing. And it just, it was topsy-turvy. It just grew sort of a thing. But it worked.
What has surprised you about VistA?
What has surprised me about VistA? Boy, I've been in it so long, it's hard to say. It's 20 years now. Probably, so when I first went into being in the IT department, and John Harvey's my system manager, was teaching us, VistA system management. Okay, fine, no problem. And he kept encouraging me to get into mumps. And at that point in time, by the way you learned mumps was you listened to a cassette tape with a book open in front of you, because there was no training. As we know, there's been no training on mumps, This is the base core thing of our electronic medical record system, but we won't teach anybody how to do it in the VA for quite some time. But that was all that was available to me, and I was able to learn mumps listening to audio tapes and looking at a book and program. And I had that advantage that I agree with. I'd never done any programming in my life, so I had nothing to unlearn. And because it was so simple, it wasn't scary. So I could start and try some things, and oh, that did work, that didn't. Oh, okay, here's how you do that. Which is another reason why I think you will find it interesting how quickly some people that you would never actually expect, if you said, well, let me just show you a little bit of this, they can run off with it. There was a discussion about the fact that people who've programmed in other languages actually have some problems with MUMP because they have to kind of unlearn what they learned elsewhere. Those of us who've never programmed before, it is one of the easiest introductions. Again, if you're at all logical or you think, you know, A plus B equals C, that's what you get with MUMPs. It's really simple in that respect. It's very easy to learn. And so I would say that surprised me because I pretty much assumed all programming languages were very complicated and mathematical, and okay, I'll try it, and then, oh, look, I can do things, you know. So I would say that probably in the end was the most surprising to me.
Is there anything else you would like to share with us? Anything you want to make sure we know?
I have lots of my own little, you know, soapbox things that I'm not entirely sure are relevant, and I would just rant off for the next 20 minutes. Not really, I would say. I'd say a lot of what I'm hearing here is exactly what I've been thinking in some cases, or it, you know, it sort of solidifies these, you know, thoughts you've had or links things together in a way they hadn't been before, but all of which goes, yes, that's right. There's a lot of that going on. But other than that, I don't think I've got anything else.
Great. Well, thank you very much.
Thank you for having me.